And we are now live, Senators.
Okay, good morning. This is March 29th, and we are in the Senate Health and Welfare Committee. This morning, we will be looking at some bills a little bit later on, in particular bills for which we have amendments. But our first order of business this morning is to welcome and interview Dr. David Merman, who has been appointed by the governor to the Green Mountain Care Board. David, want to say thank you. Is it okay if I say David rather than Dr.
Please,
Merman? That's
please.
up to you.
David's great, thanks.
Okay, good. And so what we'll do is we'll go around the table and introduce all of our committee members first, and then we'll have questions for you about your confirmation.
That's good.
Hi, I'm Senator Martine Buick. I live in Burlington and I represent Chittenden Central. Nice to meet you.
Nice to meet you.
Thanks.
Good morning, Dave Weeks, representing Rutland Council.
Jenny Lyons, Chittenden Southeast.
Terry Williams, also from Rutland County.
And Senator Hardy will be in a little bit. She's testifying in another committee. She is from Addison County. So thanks for being here. I think what would be helpful for us, we have your bio. We've looked at your information a little bit, but I think what would be very helpful is for you to talk about your experiences so far on the board. I think your appointment started in October, and just your thoughts.
So, I mean, it's been, just around 6 months here. Starting on the board is was pretty intense for me, I would say. We kind of jumped right into the ACO evaluation and budget process. At times, I would honestly say I felt like I was drinking from a fire hose of information. It's a pivot from working in clinical medicine, and the ACO is definitely a topic that I think most of us in healthcare in Vermont didn't quite understand. So there was, for me, there was a lot to learn and get up to speed on. The board itself is been a pretty remarkable organization to work with. I was, thinking about this over the last few days, about reflecting on the board and in preparation for this. And one of the things I think about has been really amazing to be on the board with is it's an organization of really highly dedicated people. They're incredibly educated. They're really smart. They're passionate about the mission of the board of improving health for Vermonters, of trying to control costs, of increasing access, of equity, of all the things that the board seeks to do. And also, though, I think what's really just inspiring about being in that group of people, with that group of people, is the dedication to continuous improvement. I mean, there's just that no one is stopping. They're constantly trying to figure it out. And it's a complicated job and a complicated task because everything's constantly at odds with each other. Every organization. I think what I've also come to terms with, or not terms with, but understanding of, is that I think the vast majority of people that are working in the industry that we are regulating are all super dedicated to the same things that the board's dedicated to: improving the health of Vermonters, improving access, trying to control costs, improving quality. But in many ways, there's differing needs of each of those organizations. And so trying to understand that balance has been really interesting. But anyways, I do think that the board staff and the board itself is really trying to continuously improve this process, knowing that, sometimes when you look back and you make decisions and they clearly seemed right at the time, that maybe we could do it better next time. And so it's really inspiring to be with that group of people. The other sort of reflection I would say that I've had for the period of time on the board is there's definitely cycles of extreme optimism that we've figured out how to do something here to get to these goals, and then sort of this realization that no, that maybe that was tried before, or that's not going to work for this reason. And then this a bit of an emotional cycle of ups and downs, of learning something new, of hearing something for the first time, and then also kind of realization that this is far more complicated than than it seemed at the beginning, and a bit frustrating in that
See that
way.
little sign over there?
It's more complicated than that.
Mhm.
Yeah,
That's our mantra in here.
Yeah.
So you stick with it. Yeah.
seems highly appropriate.
Yeah.
So I guess those are sort of initial reactions and experiences on board.
Do you, so what do you think your contribution has been to the board? Can you talk a little bit about that? I mean, you are unique on the board as a practitioner.
Yeah. I think the board and the board staff has been, so I think to some degree, and I don't necessarily try to do this, but I seem to continually bring up a clinical scenario, a patient scenario, something from my work environment, my perspective from talking with the nurses who I work with, or the paramedics who I work with, or the consulting hospitals, and try to bring that to the board, either in testimony or in our conversations with board staff. So I think that's actually been really helpful to sort of continually kind of ground back the work that we do. The staff has been really receptive and I think appreciative of being able to, like say in the certificate of need process, to be able to just talk about a few specifics that are relevant to my experience as to whether or not this is something we need to pursue or hire a consultant for or not. But I think the bigger benefit is from that I feel like I've been able to offer is that sort of the grounding patient and staff clinical experience going through healthcare from my perspective.
Can you give an example of the situations where you have brought that to the board and it might have made a difference? Or
I mean,
not?
So, I think other than sort of the specific things within the certificate of need process and, is this, I think more of them, I don't know if they've made a difference, but I've been able to, one example that I use early on is something that's, there was a clinical example of a patient who I had that I brought up in testimony one time, who was deferring care for months. So basically, he started having a lot of very concerning cardiac symptoms in around September, and he was trying to get to January so that he could get into the next year, so that all of his out-of-pocket costs would stack into the next year, because they hadn't spent a whole lot that year, and he knew something was going on. And I think maybe his wife had a surgery planned for next year, so he's just trying to get to January to get help. And it's a pretty tragic story. He died around Christmas, and I had him as a patient then, and that's when I met his family. And so I think sort of that grounding reality that every decision we make, every topic we consider has really significant impacts on individuals. System impacts, there's finances, there's data and policy, and we can look at all of that. But each one of these things, it trickles down to an individual, and they're incredibly important things. So I kind of brought that story up unintended. It wasn't prepared testimony, but it seemed like at the time it was on my mind, and I brought it up in a public hearing, and I think that so is it helpful? I don't know. Is it impactful? I don't know, but I think it's important to continually to sort of to ground these things, and so I think that's part of that.
Well, thank you for that. And certainly the things that we hear sometimes is that the board or others are disconnected from the reality of people within the system. And this is a prime example of how you're bringing that information. So that's very helpful.
Yeah, and I guess, the board is separate from the provision of clinical medicine. So in that way, it's inherently not connected. But I would say that from my conversations with board staff and board members, I do feel there's a huge dedication to be connected. And so the disconnection is more structural, I think, than it is from the personal or professional experiences of the board members and staff, or their intent. So I think that so anyway, I leave it there.
No, that does make sense, and that what you're saying resonates, I think, very much. So when you talk about structural, systemic changes, you're seeing some of the systemic regulatory pieces, the things that you're working on will have an effect systemically. They're not policy decisions, but they may influence policy decisions. Are you beginning to see any regulatory decisions that you're making, or this example that you gave, are there any recommendations that you could make for policy changes that might improve access, quality, and cost? Simple question.
Easy one.
It's a softball.
I mean, I know you say you've been reflecting, and
Yeah.
6 months is not a lot of time in this world. So.
Well, it's funny. I think so. The board, just a preamble to that, but the board cycle is a year cycle, and so a lot of it is sort of, I think that, so I do think there's a year cycle to things that will be more helpful to reflect maybe a bit after a year. And I guess I also have been more focused, I would say, on trying to understand the regulatory duties of the board than thinking of policy changes. I think policies, there's a policy person sitting next to me here too, and all of you are policy people, is really hard because as is regulation, but the unintended consequences can be pretty long-term, because it's hard to change policy. I mean, from this one example, I guess one could say, when you look at, our insurance plans available, that once you get to a certain income level, if you're buying insurance on the ACA, it makes financial sense to get a high deductible plan and get the bronze plan because it has the highest total out-of-pocket expenses, total expenses, premium and out-of-pocket. So, but I think you could use this example as an example to say there may be some deleterious effects based on that, because it does motivate particular, changes in one's access patterns to care that could have, like in this situation, I think honestly, totally preventable tragic event. So, so I guess that is, a policy idea that could come out of this, but I don't know, it'd be fun to sit and chat policy someday and reflect.
We do that every day. You're right, it is. And the example that you gave is something that we've heard about.
Yeah.
And is critical. How to solve it involves insurance companies, rate setting, and all the things that you're doing. So yeah, after a year, it would be great to hear your thoughts after a year. Really would.
Yeah.
So I'll ask one more question, and I think committee members may want to chime in. So you brought up the ACO in the beginning, and just can you give us maybe your thumbnail sketch of what you're seeing around the ACO? And I know there's a lot of work going on right now on the Green Mountain Care Board with respect to the ACO. Can you just talk a little bit about what your perceptions are at this point?
Sure. I would say to caveat this is the ACO is in front of the board right now, or about to be with its
That's
new budget.
true.
So I have to be a little bit.
Okay,
Yeah.
I don't want you to violate any
I think I can.
confidentiality.
I think I could say, again, and we've talked about this in public testimony, so I think that is reasonable. I think that the thumbnail sketch of the ACO, I think that I guess to me, one of the challenges that the board and myself, and I think a lot of people are having with trying to understand the ACO is trying to figure out the challenges of measuring its effect. And I think that's, for me, one of the big challenges on the board is trying to understand how to measure the effect and what those measurements show and who should measure. And
There are a lot of players involved.
there's a lot of players
Federal
involved.
government, AHS, Green Mountain Care Board, everyone, ACO.
Yeah. And I guess I would throw out this caveat too, that I go back to my prior comment that I think that I don't know people who work at the ACO other than the people we've met through public testimony.
Right.
But I imagine that pretty much everybody who's working at the ACO goes in every day, again, trying to make healthcare better in Vermont. So it may be that it's not the intent, it's not the desire, it's not the skill. It may be more of a structural component that we're struggling with trying to understand how to best fit the ACO into what it can be for Vermont.
Thank you for that. And that, I think that's probably a good summary of the problems that we're facing.
Yeah.
So I want to let other folks talk a little bit, but obviously you've been in a position as a healthcare provider, physician, where information is held confidential, and now you're in a place where everything you do is transparent. And so, short thoughts there. Any thoughts there about how's that working for you?
Oh, I don't know. I guess I haven't thought a whole lot about that dichotomy. I do think one of the challenges, and I'm sure you experienced this too, is that it's a public deliberation over a complex topic where you're trying to be creative. And, in an ideal world, you could have to me, the ideal world of problem solving is not to have risk involved with ideas, that you're
Yes.
able to throw out ideas and not have risk of having a bad idea, but that you get a bunch of ideas. I mean, whether it is brainstorming or some other, technique of trying to idea generate, that does not interface particularly well with public meetings. And so I think that creates,
Tell us about it.
yeah, like a lot of challenges for
Very much.
complex problem solving, and especially problem solving where, you have a lot of different organizations that are trying to protect their role within the system. And so, and nobody, I think it's hard for people to be able to take risk when that's all public. So that to me is the biggest challenge.
Yeah,
You
Yeah,
get that, even to be able to ask questions. that,
Yeah.
You're gonna be judged on. Sorry.
right.
Yeah.
If you ask a question or you say something polite and nice about something or
Yeah.
someone, you vilified. So,
Yeah.
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 It's difficult. That's inherent in public service. So.
Mm.
well, and I'm not saying that I don't think that the benefit of having a public, the benefit is important too.
Yes.
I think that I'm not saying that I don't
Yeah.
agree. I think that that's really important.
Yeah.
And this is public and people can.
Yeah.
But it adds a layer of complexity to the process. So.
Certainly, right.
Yeah.
And your comment about risk is, yeah. So questions, committee.
I have a quick comment question. Comment being, I really appreciate your CV and how well-rounded you are. I love the background in psychology and then emergency medicine, and also just your competitive athleticism that I see in here, and your artistic side, the singing. I love having someone on the board who has that kind of well-rounded background and mind, clearly left and right brained, I'm sure. That, I don't know if you want to speak to that, but it seems like it's something that is really useful.
Yeah, it's me. So I guess you've looked at my CV and I think one of the funny things I was talking to Julia about on the way over is that a medical CV, just nothing ever goes away. You just keep adding to the lectures and the publications, and
Yeah.
it seems sometimes antiquated,
Yeah.
but yes, I don't know. I think that it's not that, I don't know. I guess I was thinking more about like as an emergency physician, you have to be able to balance sort of the analytical physiology, protocols, rigor with trying to talk to somebody and trying to figure out what's going on and how can I help you, and what's your struggle today. And I guess that's where I've lived for the last 15 years cognitively, for the most part, with a lot of side interests, but that's been my professional life. So it's actually pretty interesting to come to the care board and think about things in a very different light, where a family friend of mine does health policy work and in Washington. He's in his 70s, and I called him at one point when I was applying for the job, and he said, well, he was a family physician. So he's like, so in clinical medicine, what is it? The cycle of feedback is very quick, especially in emergency medicine, where in policy work, and I would say regulation, your cycle of feedback is very slow. And he said about 80 to 90% of the time, a lot of people are going to be really upset at you. And about 10 to 20% of the time, it's all going to work out great, but you're not going to know for a few years. And so,
Exactly.
so it's been an interesting transition, and actually right now, this dichotomy of kind of going from, I'm working a lot less clinically, but I'm still working clinically, and it's great, but it's, from going from a clinical shift to a bunch of care board meetings back to a clinical shift. And that is a very different way of thinking about things. And I personally actually kind of like the separation of them, where when I work clinically, I can work clinically and there's something going on in the background thinking about care board. But
well, I appreciate your experience and your humanitarian work as well. You've worked in some different medical facilities, in the recent past.
Mhm.
Is there anything that stands out in these various locations where you've worked, and these various systems in which you've worked, that you just think to yourself, that really worked well, or this is something that doesn't work? Is there anything that has floated to the top for you in terms of your experience in sort of these institutions?
Yeah, I think that, so I guess there's a couple things there, is that, medicine, hospitals in the US are definitely not, clones of each other. They each have different challenges, different strengths. They each, excel in certain areas and struggle in certain areas. So I remember when I came to UVM, I was at UVM I started like 10 years ago this week. I was amazed at coming from Bay State of how quickly I could get CTs, MRIs, labs. The techs were awesome. The nursing ratios were way better in the emergency department. But there's other, but I think, but different hospitals struggle with different things. Sometimes, you can get this quickly at one hospital, but it's something else that's quite slow. And yeah, there's a lot.
Yeah,
trying to figure out how to
question. It's
summarize,
good.
but
You can leave it at that.
yeah.
That's fine. Yeah, I appreciate that. Thank you.
Actually, I do have a question. First off, I'm very impressed with your CV. It's the depth is phenomenal, and I think the care board can surely benefit from the practitioner perspective that you're bringing, in particular the emergency medicine. And the thing that I found most intriguing was it looks like two occasions you were doing some humanitarian assistance work in Africa, various places, and I'm wondering if from those experiences, what have you learned that you can apply to Vermont or the next humanitarian problem that's in our region, a natural disaster or pandemic? Or any lessons learned from those African experiences?
Oh wow!
Another tiny question.
See how
it's
complicated we are.
so it's interesting. So one of my colleagues at CVMC just got back from being in Chad for a few weeks, and one of the challenges I think of coming from a really resource poor area like Africa to back to the US is trying to look at the resource disparity is really painful actually to think about the differences. I went from being in Lesotho the last couple of months of medical school to being an intern with a few weeks later, and to see that, you know, our hospital in Lesotho took care of 150,000 patient visits per year on a $150,000 budget, you know, and, you know, a chest pain admission with a stress test and whatnot that we used to do pretty routinely, you know, 15 years ago, which we don't do as much now, and we try to keep things outpatient. You know, you're spending a lot of money. It takes not that many patients to add up to $150,000. So I think that's a challenge. I don't know how that relates to care board work. I haven't put the two of them together specifically, other than, I mean, I think thinking about it now, one of the things that I think is just really, really prevalent in clinical work is seeing the disparities associated with, you know, all the things that lead to disparities: income, education, family structure, income, geography, access to transportation, disability. So I think that more informs my work on the care board and my thoughts in general about health policy and equity than my experiences in Africa. I mean, I've always wanted to go back. This is throwing a little bit of a curveball in. How do you go back now that this position is, you know, committed for several years? But it's meaningful work. Yeah.
Good. Thank you.
Thanks.
Just, I'm very impressed, obviously, with your resume and your experience. And that's what I like is, as a practitioner, you're bringing that human contact information and experience to the board. Anytime I was ever in my career, I always looked at things from my boss. I want his job. You know, eventually you could become, you know, have enough interest to become the chairman of that board. And my only question is that it takes you a year to figure out what your job is. You're only gone on 6 months, and then it takes you another year to figure out how to do it. It's kind of like being in the Senate. From an organizational effectiveness standpoint, have you been observing things that, from your experience and your interoperability with other positions, that you could bring to the table to make the Green Mountain Care Board more effective? I don't want to put you on the spot.
Well, I think so. I mean, I do think that the Green Mountain Care, I mean, when I said earlier, I do think the Green Mountain Care Board is just, I mean, everyone on that board is looking for, trying to figure out how to make it more effective and improve. It's a really cool place to work, because it is, you know, it's just a lot of dedicated people who are trying to work to try to improve the system, whether it be how we think about reviewing hospital budgets, when we review hospital budgets, you know, insurance rate reviews. How do we think about insurance rates? We meet with actuaries and rethink about how to think about insurance rates, which is a complicated topic that I must admit, unless you live in that world, it's quite dizzying. So I think that I don't really think that I have a whole lot of unique additions to that, other than I feel like I fit well in that, with that group of people that are they're just constantly trying to figure out how to rejigger it to make it better, without being, you know, without swinging the whole, you know, ship in a different direction. I mean, so I guess that's my comment on that.
I know the board's been around for what, 20 years? Roughly?
No,
11.
years. So, and I mean, I don't know what I don't know, but if everybody brings that attitude to the plate and works together to make it better for the people, that's great.
Yeah, and I, you know, again, like, I'm new to the board, and Chair Lang probably has a lot better perspective on this as to what the board was like 11 years ago. But my impression is the board is a lot different now than it was 11 years ago. Responsibilities of the board, the resources the board has to evaluate budgets and whatnot seems to be significantly improved. The makeup of the board and composition, I think, has changed quite a bit over that time.
right, and the work that you're doing under 167 with the Agency of Human Services has significantly changed some of the work that you're doing, so.
Yeah.
So is there one more question? Because I think we're gonna, all right, are we good?
Thank you.
Oh, well, I just,
I hope so.
yeah, I want to say thank you. Thanks for coming in, and Julia, thanks for being here. The backup, you always have a friend to call if you need it. And we value that in here, but thank you for your commitment. It sounds like you're really passionate about what you're doing at the board. So the next step for us, so you've been through the nominating process and been interviewed by our nominating committee. And then you have had your name given to the governor, and he's picked you out of the names that were given and brought you to us. And we'll have a vote at some point, and then we'll send your name. I'm not thinking we won't be sending your name to the full Senate for confirmation. So that's some reassurance from us, unless I hear differently from my committee. So thank you for being here.
Thank you.
Good luck.
Thanks
Yeah.
for the
Thank you so
opportunity.
much.
Thanks.
Thank you.
We can pass this chair to someone else.
All right. So we're gonna just take a second break, and then we're gonna move on to H-190. We're looking through bills. We're gonna look through this bill first. We might be able to take a break after this one. but Go ahead.
I'll be super quick. And you can start if you want.
Yeah, we will.
Last
Glad you
week,
let
we
me
had
know.
a vote, and I was the acting clerk.
Yeah.
And I never did fill out
He's got the form.
you got it?
Yeah.
Okay.
so
You
got
don't
it.
actually need it, it's just
Okay,
a
all
record.
right,
Yes.
thank you.
You do need it. for the
Yeah,
record.
yes. I need
I
it.
don't.
Rephrase
You
that. Alex needs it for the
Right.
record.
Now I can just file
Yeah,
that away.
Okay, but good, that's a good thing, that's your job, and keep us honest on that, make sure we do have our records organized. Okay, so, we'll bring David's name in at some point when you want to bring up yeah, so,
Good morning.
good morning. So Ray, thank you for being here. We're now moving to H-190, and it's posted on our webpage.
Would you like me at the,
Yes, please.
nice to see you.
Good morning.
I don't know everybody.
Good morning.
Good
So
morning.
we're going to introduce ourselves
Great.
so you know who everyone is. And Senator Gulick has just stepped back in. So Senator Gulick will introduce yourself. We'll begin with Senator Hardy.
Hi, Naomi, Rick Hardy.
Nice to see you.
Terry Williams from Rutland District.
Nice to meet you.
Jenny Lyons.
Dave Weeks, Rutland County. Nice to meet you.
You know me too, my team.
All right.
Chicken Central, yeah.
So thank you for coming in this morning. Why don't you just give us a quick peek at H-190? You're the reporter of the bill, and then we'll go through the bill more thoroughly with Jen after you're finished.
Sure. For the record, Representative Vega Garofano, Essex and Essex Junction. Thank you for having me here. H-190 is a bill that amends the patient choice at the end of life law. The law has been in existence in Vermont for approximately 10 years. And this bill amends it to remove the residency requirement. Basically, knowing that medical care is available regardless of where you live is a central tenet of public health. Currently, end-of-life care is the only healthcare in Vermont that requires that the patient be a resident of Vermont. And there's no justification for that. We don't put residency requirements or those parameters on any other healthcare in this state. Thus, this bill will allow patients to make choices at their end of life, regardless if there's a code. and be able to make decisions surrounded with their family, with care, and with their physicians. So this bill specifically removes the requirement that a patient who is terminally ill must be a Vermont resident to be prescribed medication in accordance with Vermont's patient choice at the end of life laws. Specifically, it makes changes in two areas, which I'm sure Jen will walk you through. The two areas are the definition of a patient and the requirements for prescribers. So that's it, and it just.
So this, how did this pass this is out of, House
Human
Human
Services.
Services.
1100.
It was 1100, okay, and then, on the floor, how did it go?
Voice vote.
Voice vote.
And I will just note that the New York Times published an article today covering our law and the proceedings here, which is kind of showing that this is needed across the country. There's currently 10 other states and the District of Columbia who have this law on the books. And I think it's great that Vermont is leading the way in helping families make medical decisions.
Thank you. Yeah, the New York Times person is in here as well. Okay, questions? Go ahead.
What's the conceived scenario that someone is has a second home here and they have they're in a medical distress and they decide an end of life procedure is appropriate for people who are coming into the state for hospice service, service. I'm just kind of curious what the genesis of the.
Yeah, we heard in testimony that typically we envision families using this who have ties to Vermont and have family here, children here, or from here, moved away. That's typically who would be using it. I will say neighboring states that don't have this law, people there who are terminally ill may, utilize coming into Vermont to take advantage of this law to make this decision for their health.
One of the things that we'll have Jen remind us of is all the other provisions that are around this.
Nothing's changed.
Yeah, and nothing has changed.
Yeah, this law only changes the residency requirement.
Oh, sorry.
Go ahead.
I just want to say thank you for bringing this to us. I started following this story maybe about a year ago. And because I honestly didn't know that this was such an issue. But as a country, as a state, as a country, I believe so strongly that we need to get better at end of life care, patient choice, death with dignity, all of these things. It's just, I find it tragic the way we handle some of these scenarios. So I really appreciate that you brought this bill forward. Thank you.
Of course, and I'll also share personally, unrelated to this and before this came about, but this made me really think about how we do it in Vermont is my family took advantage of this in December. My mother-in-law was terminally ill. They live in Canada and she was suffering for a year. And to have the time and have her be able to make this decision on her own, surrounded by family members, with her two children, and having all of us there, including my 12-year-old child, to be able to say goodbye to their grandmother, it was the biggest gift our family could have received. And, if anybody has any doubts about this type of procedure, I will let you know personally, coming from a family that's very spiritual and religious, we all so appreciated that the medical system in Canada allowed this. And I'm so proud to live in a state that also provides this for its residents and now residents of other states.
Well, it is pretty amazing. I didn't realize there were 10 other states in DC. Because
Yeah.
when we started this was Oregon.
Yeah. We followed Oregon and hopefully we'll pave the way for the residency requirement as well.
Yeah. Thank you for your testimony.
Of course.
This is really helpful. Are there other questions?
No, thank you.
Thank you very
Thank
much,
you.
Representative Garofalo.
Thank you very much.
Appreciate you for being here. Okay, Jen, you want
Good morning.
to, good morning.
Good morning.
Thanks for being here. It's
Sure.
good to see you again at the end of the table. We've been so busy.
So Jen Carvey, Legislative Counsel, I think it'd be helpful to just point out, you do have a Senate companion bill that we walked through a couple of months ago, S26. So if this subject matter sounds familiar, we did take an initial visit on this topic in S26. I look back, it was, I think, February 2nd. And I put up the laws at that point, which we can do again, but just to go through the process of what is involved for a physician to prescribe this medication.
I think it will be helpful. I know that my conversation with the Chair of Human Services was who was going to do this first, right? And so that always happens. But members of the committee sitting here, some of them are not familiar with the underlying statute. So if you could just give us a picture of what is involved in end-of-life choices, that would be helpful. Patient choices of care.
Sure. Do you want language up or you just want to talk more generally?
Let's start with more generally,
Okay.
and then if we need language up, we'll go there.
Sure. So the way Vermont's law on what we call in the statutes patient choice at end of life, but variedly goes by names like death with dignity, physician-assisted suicide, and most currently medical aid in dying is the term I've been hearing. In Vermont's laws, the process for this is it's for a patient. So to be eligible, you have to be a patient with a terminal condition, a diagnosis of a terminal condition, and that is an incurable and irreversible disease that would, within reasonable medical judgment, result in death within 6 months. So a patient with a terminal condition can request medication from a physician that must be self-administered. So they have to be able to give it to themselves. It's not somebody else delivering that medication. Self-administered to hasten their death. So bring about their death at a time of their choosing. And so the way Vermont statutes are framed is really through the lens of the prescriber. So the main statute that sets out the process is 18 BSA section 5283, and it gives immunity to a physician. So they're not subject to any civil or criminal liability or professional disciplinary action if they prescribe this medication to a patient with a terminal condition, medication to be self-administered to hasten the patient's death. And the physician must affirm in the patient's medical record that a whole list of actions occurred. And so you may remember that we had gone through that list in the past, and it starts with the physician making an oral request to the physician for the medication. And last year, this committee and then the full legislature allowed the use of telemedicine.
The patient making the request.
Yes, what did I say?
Doctor.
Oh, sorry. Patient makes the request to the physician. Edited. Important. Yes. So the patient has to make the request to the physician, either in the physician's physical presence or by telemedicine. That was the piece that was added last year, if the physician determines that using telemedicine is clinically appropriate. So the patient makes this request for the medication to be self-administered for the purpose of hastening the patient's death. And then at least 15 days after the first oral request, the patient makes the second oral request to the physician. And at the time of the second oral request, the physician offers the patient an opportunity to rescind the request. The patient can rescind the request at any time, but there must be at least this specific instance of the physician offering to the patient an opportunity to rescind the request. And then the patient must also have made a written request for the medication. So 2 oral requests, at least 15 days apart, and a written request for the medication signed by the patient with 2 or more witnesses who can't have any involvement in the patient's care or be family members or be anyone who's going to inherit if the patient dies, who have to sign and affirm that the patient appeared to understand the nature of the document that they're signing and to be free from duress or undue influence when they signed the document. The physician has to make a number of determinations about the patient, including that the patient is in fact suffering a terminal condition, based on the physician's review of the patient's medical records and a physician, whether it's the same one or another physician's physical examination of the patient. It must have ensured that the patient was capable, so was able to make an informed decision, was making an informed decision, had made a voluntary request for the medication, and then, and this is one of the pieces that would change, that the patient was a Vermont resident. So in the underlying definition of patient for purposes of this chapter, it requires the patient, the individual, to be a Vermont resident. And here the physician must have determined that the patient was a Vermont resident. Those are the two pieces that the bill would be taking out. All of the rest of it remains. So then there's a bunch of information that the physician has to inform the patient about their diagnosis, their prognosis, the range of treatment options. If the patient is not already enrolled in hospice care, then the provider has to tell them about all feasible end-of-life services, including palliative care, comfort care, hospice care, and pain control. The range of possible results, including potential risks with taking the medication, and the probable result of taking the medication, the probable result meaning death. The physician has to have put in medical record that they referred the patient to a second physician for medical confirmation of the diagnosis, prognosis, and determination that the patient was capable, acting voluntarily, and had made an informed decision. So 2 physicians involved in talking to the patient and confirming the diagnosis, prognosis, the patient's capability, ability to understand the decision that they were making and to make an informed decision, and that they were acting voluntarily. Physician either has to have verified that the patient did not have impaired judgment or referred the patient for an evaluation by a psychiatrist, psychologist, or clinical social worker licensed in Vermont to confirm the patient was capable and did not have impaired judgment. There's a requirement for the physician to have consulted with the patient's primary care physician with the patient's consent. The patient has one and it's not the same physician. The physician had to inform the patient, as I said, that the patient can rescind the request at any time and in any manner, and have offered that specific opportunity to rescind at the time of the second oral request. The physician has to ensure that all of the required steps were taken out as listed here and confirmed just before, immediately prior to writing the prescription, that the patient was making an informed decision. And then the physician has to have written the prescription after the last to occur of the patient's written request for the medication, the oral request for the medication, and the second oral request, and the physician offering the patient an opportunity to rescind the request. So all of those things must have happened before the physician wrote the prescription. And then the physician either dispenses the medication directly to the patient or, with the patient's consent, contacted a pharmacist, informed the pharmacist of the prescription, and delivered the prescription either personally or by mail or fax. And then the physician has to have recorded a whole bunch of information in the patient's medical record about all of these determinations and the time, date, time, and wording of the oral requests, the second physician's role, the patient's enrollment in hospice care, or that the physician informed them of end-of-life options. And then after writing the prescription, the physician has to file this report where they document that all these things happen with the health department. And there's also, as I said at the outset, there's immunity from liability for having taken these actions, but it specifies that this action shall not be construed to limit civil or criminal liability for gross negligence, recklessness, or intentional misconduct. So they have to have acted in good faith, and that's elsewhere in the chapter as well. So that's the process. And so of all of those pieces, what the bill would be taking out is really the requirement that the patient underlying this whole process must be a Vermont resident.
Questions? Yeah, okay.
So. Temper this. Has anybody ever said, does Medicare pay for any of this? Is there any insurance that the taxpayer pays for it or all of this? And it's, I'm not gonna relitigate the death with dignity, I know that's law, but I got a question about how much it costs. And it seems like quite a drawn out process, and I understand there's a reason for people to, you know, maybe change their mind.
If I may, will look to Jessica, who just walked into the room, because I think she may be more current on this information. Is that all right, Madam Chair?
Yeah.
Jessica Oskey, from the Craftsman Group for Patient Choices Vermont, and no, Medicaid does not cover the cost of this. There is, I believe there is a directive at the, at DFR, saying that private insurers do cover this if they are Vermont licensed insurance companies, that they do cover the cost, but Medicaid does not.
Let me just see too.
And hearing the question, maybe we can, we'll have to reach out and identify as what the federal coverage might be.
Yes, I think there may be some limitations of the
Yeah.
federal
I
level.
would think so.
But I
Yeah.
also think-
Go ahead, Senator Weeks, you have a question.
Yeah, let's wait.
Oh, yeah, whenever you're.
Sorry.
It's early.
Yes.
So two questions. One, so is there anything in the revised bill that protects the Vermont physician that it prescribes the medication and deals with the patient to be prosecuted by the home state of the patient?
So the testimony that I heard in the House was that the recommendation is that patients use the medication in this state and not bring it back
So
to
that's in
another
the
state.
language. is in-
It's not, that is not specific. That was the guidance that I think was being provided to physicians. We can only protect we can only dictate immunity for our own laws, so we can't control what other states would do. But for an individual to have traveled to Vermont, used Vermont's law and taken medication in Vermont, I think it's a further stretch to have a nexus to the home state at that point.
Okay, I thought we did something similar to this, though, in the abortion.
S37.
There were some elements of that were looking to the extent possible to protect Vermont providers from actions from out of state. There's not similar language in here creating the same kind of shield.
In your, in the House testimony, was that being necessary or irrelevant?
No, we didn't hear anything in testimony in our committee that recommended having those additional protections.
Then from the legal perspective, you don't see risk to Vermont physicians if they,
I think there is potentially greater risk to physicians if patients are not Vermont residents, but I don't know the significance of that exposure. So
you don't see it differently than the, was it 36?
37.
37.
I see, I mean, I think there are some distinctions there. For one thing, I don't know that there does not seem to be as much of an active effort in other states to prohibit this activity or to limit the ability of their residents to travel to use these laws. I feel like the legally protected healthcare activity we were looking at in the context of S37, there are very active disagreements among the states about what is and is not allowed. And there are efforts from some other states to try to reach into states that allow that healthcare activity and regulate there. I'm not aware of similar efforts in the context of medical aid and diet.
I'll just add, I think in other conversations that I've had, is that's exactly the distinction, is with reproductive rights, there is actual legislation being proposed prohibiting it, making it illegal in other states, whereas with this law, end of life is not necessarily explicitly prohibited in other states. So there's not an active legislation making it an illegal act.
But I do think it is safer for, there's less potential for liability for the provider if the patient uses the medication in Vermont, because the process and the prescription are legal and the use is legal, is specifically authorized under our statutes, whereas other states without medical aid and dying laws are silent.
All right, second question. So the current bill allows telemedicine to be as part of the interview process or the physician-patient process.
Yep.
Anything to prevent a Vermont physician from conducting telemedicine to an out-of-state patient and prescribing medication?
So the physician has to be licensed where the patient is, and the location of the patient dictates which laws apply to the patient. So if a patient is outside of Vermont when they are engaging in this process, then Vermont can't shield the provider from unauthorized practice and the provider.
But is the bill in fact trying to generate that type of protection?
I don't believe so. The rationale for adding the telemedicine provision last year really had to do with the difficulty of many patients who are in an end-of-life stage in traveling to a physician's office to have these appointments.
So, part of our job is to determine unintended consequences.
Yep.
One unintended consequence, and I'm just asking, would be a Vermont physician prescribing via telemedicine end-of-life medications to an out-of-state and present, that they're present out-of-state, not just an out-of-state resident, but they're in another state. I just wonder.
I think that's an education issue for the provider community. And so I know you have the medical society here, and the health department has been very involved in this as well. So I think that's a matter of educating physicians that these provisions do not apply when a patient is not located in Vermont.
Physically
Yeah,
located.
these
Physically
are
located.
good questions. We'll get the Department of Health and to testify.
That's it.
Any other?
Just a follow up on that.
Okay.
So if somebody is licensed, a physician in another state is licensed to be able to treat under Vermont law, does that mean that they can administer the prescription in another state?
Where the patient is physically located determines which laws apply.
Okay.
So if the patient is not in Vermont, what this bill is doing is saying the patient doesn't have to be a resident of Vermont, but we can only authorize this process
Physically.
if somebody is in the state.
What about, and I'm not sure if I have the right word, cohort, it's where states coordinate.
Compact?
Compact. So the compact doesn't change that?
Then no, I mean, the compact would allow physicians to be licensed in other states.
Okay.
Whether an out-of-state physician who is licensed in Vermont and doing telemedicine with a patient who is physically located in Vermont would be allowed to use this. I think that would really be up to the state. I don't think that's a problem under Vermont law, but it may be a problem under their home state, the state that the provider is.
Right, so again, it's
But
I
we
know it's not
can't,
the
right.
intent of the bill, but you gotta look at, what.
Right, and again, that's I think an education issue. We can only regulate, within our borders, and we can educate providers about where the limits are for their own liability protection.
And I'll say, when you have the health department, and they have really great data on the number of physicians, the number of, people who've been engaged in this process for the last 10 years.
Last question.
Oh, well, I was just gonna add something to this discussion that in terms of the telehealth conversation, last year, we did a bill that added the ability
Right.
to use.
We were just
talking
talking
about
That's
that.
what we're
Okay.
talking about.
That's
Okay, sorry, I
exactly,
missed that. But there were,
We just did it again.
discussions about that it would be only if it was medically appropriate or something. I can't remember the-
Clinically appropriate. Yep.
Yeah, and so a physician that didn't think that doing, the consult via telehealth was comfortable or professional, medically appropriate, wouldn't do it. So, there's also that sort of protection involved that, in many cases, they would say, I think we need to see.
so the scenario that I'm trying to articulate is a Vermont physician via compact agreement with another state that doesn't have this law or any death with dignity law
Mhm.
administering for the non-resident, non-physically present patient. That's just what I'm just taking away from that. Thank you.
Yeah.
Okay, so good. And when we have Department of Health, then we'll probably get into this again a little bit. No, there's some of us have been through it, but others of us haven't. So it's important to have that information.
And I will get more current information about Medicaid and insurance coverage.
Yeah, that'd be great.
Do you want to, did you guys see I can send you the link to the article that,
I'd love that.
yeah.
I got it. Okay, so let's, Jen, thank you. We'll be coming back to this one. We'll line up testimony and come back to it again. But this is our first look at it. Thank you very much for your testimony, Representative Garofano. It's very compelling, especially your own personal story. Appreciate it.
Thank you.
Thank you.
All right. So Eric is here.
Yes, hi, good morning.
Good morning. So just as a reminder, we went through S91 last week and found a couple places we might like to propose an amendment. Unfortunately, we don't have the bill and we won't be getting the bill. And we understand we'd like to have the bill move forward. This is one of two mental health bills that have come to us from the judiciary. And within the bills are areas that relate to our jurisdiction. So I did work with Eric to put together the amendment based on our conversation last week. It should be, I mean, we can all sign on to it. It doesn't have to be a Senator Lyons amendment. It can be an everybody amendment. I'm not sure we can do a committee amendment on this, but that's a process question.
That's right, Senator Lyons. I checked that with John Bloomer. You're exactly right. It's you can have, all members of the committee listed individually, but for, I'm never sure exactly the reason for that rule, but but that is the rule. You can't be phrased as a committee amendment at this stage. Yeah.
Okay, so what we'll do is, Eric, why don't you remind us of where these fit in the bill and show us the changes that we're requesting. And as an FYI, I have talked with the pro tem about having members sit off session and receive per diem. I've mentioned it to the chair of appropriations, and I've talked with the chair of judiciary about what we have here. And judiciary, I think, is looking at this proposal, should we decide to go forward with it after we finish with it. Is that accurate, Eric?
Yes. Yeah, I think they're 11:40, I think, is when they're going to look at it later this morning.
Okay, good. All right. So why don't you share with us what we have here?
Sure. Good morning, everybody. Eric Fitzpatrick with the Office of Legislative Counsel, here to talk with the committee about possible amendment to S91. It sounds like, folks have I know Alex posted it, so folks have the language, you're able to take a look at it? Or,
I actually don't
Yeah, but
see
can
it.
you post, can you?
You can, if you share your screen and put it up, that some folks don't have.
Oh, sure.
Yeah,
Yeah.
I had to do it twice. before it
It's
came
the
up.
Lyons amendment on.
Yeah,
That's
on
91.
91.
shall I share the screen just so everyone can see it?
I think that's helpful for those. who are
Yeah,
listening.
no, fine.
Doesn't help
I can
me.
bring up
I
my
can-
laptop.
Let me give it a try.
Did he?
I had some-
Yes.
Yeah, okay.
Oh, I got it.
Right.
Anyone want?
Is that visible?
That's good. There we go. I might want.
You can see it okay?
Yep,
We're
thank
good.
you, Eric.
Okay, great. So there are essentially two proposals of amendment here to think about. One of them involving the competency restoration program that's in S91, and the other one involving the Joint Legislative Justice Oversight Committee's review and study this coming interim period. So the first one, the competency restoration program, very straightforward. See, I think this committee had noted that the restoration program plan that was required to be developed by DMH and Dale did not note that they would be consulting with other interested parties. And so the simple addition in language is highlighted in yellow on line 7 and 9, so that this plan on competency restoration, and in fact, let me backtrack a moment, first of all, has to be a recommendation on whether a plan for a competency restoration program should be adopted at all. That's in lines 10 and 11. So first recommendation is on that decision point, whether or not to recommend the existence of or the adoption of a competency restoration program plan. And if that's the case, if they do recommend one, then the report would go on to include recommendations for, and this is lines 13 and 14, best practices, changes in law necessary to establish it, cost, implementation proposal, etc. However, as I mentioned, it was only DMH and Dale as initially drafted without consulting other folks who would be interested parties and obviously have a lot to say about this issue. So the proposal is to add that language to require that interested parties be consulted in line 7 and 8. So that's
Okay,
the first one.
Yeah, go ahead. I don't see any hands going up, or Eric, so just keep going.
Okay, will do. Sounds good. So section 8, this was the Justice Oversight Committee review that I mentioned. Remember, this has to do with the issue that the committee's talked about of expanding who can conduct these preliminary psychiatric examinations during competency and insanity defense proceedings. Because the way the law is right now, it has to be a psychiatrist who conducts that initial examination. That's unusual in terms of all other 50 states. I think that the testimony was that only Rhode Island is the only other state in which that initial psychiatric exam has to be conducted by a psychiatrist, and most states do permit, forensic trained psychologists to do that. So the underlying bill, remember, has that provision that expands the ability, the types of professionals that can conduct that initial evaluation, and it expands them to include doctoral level psychologists trained in forensic psychology. And it has a sunset. I remember it has that 1-year sunset. So that expansion only lasts for a year. And during that interim year, Justice Oversight is meant to study the issue. And there's this existing language in S91 that says during that year, during the off session, Justice Oversight has to study, whether that's an appropriate expansion to include doctoral level psychologists. And not only that, but whether there might be other medical health professionals who should also be permitted to conduct those evaluations. So that's in the underlying bill that came over to this committee from Senate Judiciary. Then the additions really involved, the scope of Justice Oversight's review, and also how Senate Health and Welfare and House Healthcare, excuse me, members would also be part of that review. So the first piece here has to do with the scope of the review. I just talked about what it was meant to include, first of all, but there's also some specificity that's proposed to be added here, that the review would also include consideration of laws on the issue in other states. So in other words, what other professionals might be permitted to conduct these evaluations by other state law, sort of making sure that justice oversight looks at that issue as well, and whether there are any changes in Vermont law that might be necessary to permit referral of the evaluation to a psychiatrist when appropriate. And that was I think the issue the committee discussed about, well, there might be situations where there's an underlying medical condition where it might not be appropriate for a psychologist to conduct the evaluation. So this is just meant to make sure that justice oversight considers that point as well. You know, whether or not the statutory language in 4814 is okay as is, or whether there might be other changes necessary to make sure that if the circumstances warrant it, that it would be a psychiatrist rather than a psychologist or some other professional who conducted the review. So that's that first change. Second one is the one, Senator Lyons, I think you were mentioning just a short while ago, and this is more of a process change rather than the scope of the report itself. And this has to do with the participation of members of this committee and House Healthcare. So you'll see that it requires that, first of all, justice oversight re-examine this issue, and this is line 11, in no more than 4 of its meetings. So it says, all right, take 4 meetings and look at this issue. Secondly, that second sentence, 2 members of Senate Health and Welfare and 2 members of House Healthcare shall be permitted to attend and participate. And then the last sentence, the members who do attend and participate will also be permitted to participate in the development of the plan, the recommendations, and the report. So they wouldn't just be, in other words, there, you know, at the meetings themselves, but then also would be participating in the report about whether or not, you know, the language should be expanded to include other professionals to conduct the evaluations, or should it be left as is? That would all be with the input of the healthcare members that attended the meetings as well. And I think that's it. Or was there something else? Oh, right. Sorry. Yes, the very last piece was that that the report itself would not only come to the Judiciary Committees, but also to the this committee and the House Committee on Healthcare.
Okay, questions, discussion? I think it kind of fits with what we had talked about.
It looks good to me.
Yeah, okay, good. So why don't, so would you like to be on this proposal of amendment?
Sure,
Thank you.
I'm game. Yeah, let's do it.
Anybody not want to be on? Okay, so Eric, if we could just put all of our names on the thing, and then when it's time, I'll stand up and talk about it for a little bit. Hopefully the Senate Judiciary Committee will support it as well. We'll see. Thank you for.
Okay, that sounds good. I'll put, sure. So I'll put everybody's name on, all 5 members of the committee. And then I'll send a copy back to you, Senator Lyons, and I'll CC Alex as well. I think, I don't know what the timing plan is, but I think at some point you need to bring it to John Bloomer probably, right?
Yes, I think it's gonna be today, so I'll just take it up with me and we'll probably hand it out on the floor.
Oh, okay.
Because hopefully Judiciary will have seen it by then and given their thoughts. We'll see how it goes.
Right. Yes. Like I said, hopefully they'll be looking at it later this morning.
Terrific, thank you. And it's interesting because at the Judicial Mental Health Council meeting on Monday, we did talk about this bill as well as 89, so, or at least conversation about it. Important. All right.
All right. Thank you.
Thanks, Eric.
Thank you.
Yep. Bye-bye.
Do you anticipate that 91 and 89 will hit the floor for
I
vote?
think so. I think
I know
there's
that
an
was
in
good.
because they're S bills, and these are these are important bills in terms of mental health and competency, getting the backlog of judicial system removed, getting rid of that. So, yeah, I think it may happen today. So what I'm going to suggest is, what time is Katie? Is it
10:30.
What I'm going to suggest is that we go off live.
Yep.
And that we take a 10-minute